Good afternoon or good morning, everybody. This is Jessica Solomon Fisher from the Public Health National Center for Innovations, and I'm pleased to welcome you to our final town hall for the Futures Initiative, revisiting the 10 essential public health services. Thank you so much for joining us. A few logistics before we get started. All participants will be in mute, and when we get to the discussion portion, we'll unmute your lines one at a time if you raise your hand to speak. We'll then call on you, but you'll also need to be sure that you've entered your PIN in order to talk. So there are two ways you'll be able to communicate with us. You can use the questions box on your screen to ask a question at any time, or during the discussion portion, you can raise your virtual hand and we'll call on you, unmute you, take your question, and then put you back on mute. And the reason for that is because we have a large number of folks on the line today, so we want to minimize any background noise. But again, if you do plan to speak verbally, you'll need to be sure that you've entered your PIN so that we'll be able to hear you. We'll also be using polling software later, so be sure to stay close to your phone or computer, and when it's time, we'll ask you to open another browser and go to a website. And we are recording this town hall and we'll make it publicly available later. So what we'll be doing today is providing introductions, the purpose and overview of the Futures Initiative, a little bit of history on the 10 essential services, but really wanting to spend a bulk of the time with feedback and discussion for you. Just a little bit about the Public Health National Center for Innovations. We are a division of the Public Health Accreditation Board. It's our goal to empower health departments to drive change and improve health through innovation. And we are very pleased to be partnering with the Beaumont Foundation on the Futures Initiative and think that we're very well situated as a division of PHAB to work on this project that really aims to look at the framework and consider revising it with the public health community. And you'll hear that quite a bit throughout the presentation today, that this isn't something we're doing alone. We're doing this in conjunction with all of you on the phone and others. So with that, let me turn it over to our colleague, Katie Sellers at the Beaumont Foundation, to give you a bit of history on them and the interest in this project, and then we'll dive into the details. Katie?
Great. Thank you so much, Jessica, and thanks to all of you for participating today. We know you have a lot going on at work and really appreciate that you were able to find an hour to join us today to take part in something that we think is really important, and I think your participation suggests that you think it's really important as well. I want to start by just saying a little bit about the Beaumont Foundation and why we came to be involved with this project. So the Beaumont Foundation was founded by someone named Pete de Beaumont, and he was a mechanical engineer who developed practical tools. He launched a company called Brookstone, which at the time sold practical tools, hard to find tools like dental clamps and dovetail saws through a mail order catalog. Back then, it didn't have outlets in airports and it didn't sell massage chairs and neck pillows. But he retired in 1980 and he sold Brookstone to the Quaker Oats Company. And he made some money on the sale, of course, and used those funds to start the de Beaumont Foundation in 1998 with a mission to improve public health. Today, our mission is to advance policy, build partnerships, and strengthen public health to create communities where people can achieve their best possible health. Next slide, please. A while back, we noticed that the 10 essential public health services were reaching their 25th birthday, and we thought about all the things that have happened in the last 25 years that have had a major impact on public health and our nation more generally. Things like September 11th, which changed the way we think about emergency preparedness and response. The Master Settlement Agreement, which gave us a new way to approach corporate responsibility. Globalization, the smartphone, school shootings, marijuana legalization, informatics, Obamacare, major demographic shifts, and public health accreditation, just to name a few things that have happened in those last 25 years. And accreditation may not be huge in terms of a cultural shift in America generally, but it is really important in terms of how we do public health. So we were thinking about all that had changed and all the things that could change in the next 25 years. No doubt lots of things we can't even conceive of right now. And we decided it was a good time to take another look at the framework. In a lot of ways, the 10 Essential Public Health Services is a practical tool. And so much of what we do at Beaumont is to convene people and get the best ideas to use to strengthen the public health system. And PHNCI really seemed like a natural partner, an organization that is driving and supporting innovation, that is looking ahead and trying to make sure health departments are going to be able to address what comes next. And of course, their association with PHAB, which of course has the standards and measures that are based on the 10 essential public health services, also made a lot of sense. So we worked with PHNCI to put together a task force that could guide this Futures initiative. We invited a diverse group of leaders representing state, local, and federal public health, non-governmental public health, foundations, academic institutions, nurses, advocates, and other partners to serve on the task force. And the answer was an enthusiastic yes. All of these people we invited essentially said yes, they would be glad to be part of this initiative. So we've oriented the task force, and we'll start meeting with them once all of the input from the field has been collected and summarized. The vision here is that we'll gather feedback from people who are actually working in the field of public health to find out what they see on the horizon, to learn from them, and by that I mean you, how we may need to change our organizing framework so that we can be ready for the public health challenges we'll face in the next 25 years. We've been having a lot of conversations with people and gathering feedback during meetings and online. And as Jessica mentioned, this is our last virtual town hall, and we're really excited to hear what you think. We think this is really important work. We think hearing your voice as part of this is absolutely critical to moving forward. There's a lot that we do in public health that's remained the same over the last few decades, but there's a lot that has changed. The 10 essential public health services is used for a lot of different things. The field really relies on it as an organizing framework. So we want to make sure that we have the right framework for the future, and we're really glad you've decided to help us create that. Next slide, please. So some of the things we're considering as we go forward and that we'd really love to engage you in is for whom, so answering the questions, for whom is the framework intended? What is the purpose of the framework? What elements and definitions should the framework include? And how should we update the framework to reflect current and future public health needs and practice? So with that, with those questions in mind, I'm going to turn it over to my colleague at PHNCI, Reena Chudgar.
Great, thanks, Katie. Next slide. To answer the questions that Katie just mentioned and more, and really to achieve the purpose, we are undertaking a series of activities, which you'll see reflected on this slide. We have completed both, we've completed an environmental scan, as well as you heard Katie mention, we're engaging a task force, both of which I will touch on in just a moment. But we're currently in the final weeks of our data collection phase and have several different mechanisms we've undertaken to collect data for this effort. We've conducted live crowdsourcing at different events, think tanks, through national partner organizations, an online questionnaire that just closed last week, and these virtual town halls, which is why we're all here today. To reiterate a point that's been made, we really want this effort and this refresh to be something that's done with the field, not for the field, and that's really why we're here and have engaged in a variety of different data collection input to get the field's participation. Next slide. So as Katie mentioned, this slide shows our task force members and liaisons. Again, these are leaders, subject matter experts, practitioners from the federal, national, state, and local levels, governmental and non-governmental, really comprising a large swath of the public health workforce, and have expertise both in public health at large, as well as in specific topics that we know are issues that are relevant to the field, such as health equity. Next slide. And as I mentioned briefly, we also conducted an environmental scan, which is available on both the PHNCI and the Beaumont Foundation websites. to acknowledge the 25th anniversary of the Essential Public Health Services and their significance to public health by really documenting their history and the breadth of use and impact to the field. The 10 Essential Public Health Services has served as a description of activities and a roadmap for local public health systems as they've undertaken their work in their communities to really carry out the mission of public health for the last 25 years. And we've seen them practically implemented in a variety of different ways. We definitely recommend you read the environmental scan when you have a few moments. It's full of great information around the 10 Essential Public Health Services. Next slide. We wanted to highlight the history of the 10 Essential Public Health Services and some of those use cases, again, to acknowledge their impact, but really to understand what we are building on for this effort and the impact that this effort really has the potential to have on the field as we think about current and future public health practice. Given, as Katie describes, many of the changes and challenges, both in terms of what public health does and how it does it over the last 25 years, many public health leaders do agree that it really is time to revisit whether and how the 10 Essential Public Health Services can better reflect where public health is going and really to be used to create communities where people can achieve their best possible health. So that's why we're here today, to get your input into the framework. And with that, I'll turn it back over to Jessica.
Thank you. All right, so now we get to hear from all of you. I'll invite you all to go to, in a separate browser on your computer or on your phone or tablet, to go to slido.com. That's S as in Sam, LIDO.com. And the join code will be EPHS. I'll give you all a moment to do that before we ask our first question. So again, slido.com, join at EPHS. So our first question is an easy one, which is just what type of organization do you represent? And you'll see answers come in as everybody participates. All right, lots of health departments on the line, some nonprofits, some students and academia. Fantastic. Give you another moment to do this one. State health departments seem to be growing in terms of percentages. Some federal partners, that's great. All right, let's move on to the next question, which is, what do you see as the emerging public health challenges in the future? Be sure to hit submit once you've typed your answer. Behavioral health, fighting oppression, climate change, got some social determinants of health and equity, the environmental impact on health, funding, sustainability, mental health, social isolation, more work and fewer resources, lack of funding, economic inequality and unaddressed racism, addiction, racial discrimination, I saw something about nursing, housing, adaptability, rural areas, vaccination rates, capacity for informatics, protective factors for youth, political divides, antibiotic resistance, ACEs, access, prioritizing prevention, collaboration across sectors, in particular with healthcare, workforce shortages, white supremacy, capitalism, misinformation, toxic stress, preparedness, adequate pay for staff and public health, aging, climate change, burnout, vector-borne disease, power imbalances, an unprepared workforce, gun violence, recruiting and retaining staff. These are great. We'll give you just another moment on this one. lack of faith in science, defining public health scope and relevance. All right, let's go ahead and move on to the next one. What public health functions are essential to meet these emerging challenges? Think about the functions. Policy development, preparedness, engaging community partners, management and change, response. I saw something about data, a few things about data, interprofessional education, policy development, EPI, timely data, data collection, technology, cross-sector leadership, well-trained staff, communication, competent workforce, working across boundaries, health equity in all policies, organizational competencies, anti-racist work. I saw something about marketing, engaging the whole community, the influence in policies, communication strategies and social determinants, using sound science, all 10 of the existing ones, quality improvement, political acumen, racial equity impact analysis, marketing, sustainability, social media. I think that's one we haven't seen before. A diverse workforce, meeting people where they are, business strategy, civic engagement, great. We'll give you another minute. Vaccinations, all of the foundational public health services, grounded in values, funding, flexibility, so responsiveness to change, global awareness. These are great. All right, great. Let's move on to the next one. What one word do you see when you think of the essential public health services? And this will form a word cloud, so we'll see whether you're all thinking along the same lines or have different thoughts. Go ahead and type in that one word or phrase. The framework and essential kind of rising to the top so far with our few answers. But they're still relevant, broad responsibilities. Prevention growing pretty large. Oh, that shrunk. Core, public, human, policy. Policy showing up in a couple of different ways. Access, vital, structure, skills, PHAB, old. Great. A lot of you thinking along the same lines, it looks like. Public Health 2.0 as opposed to 3.0. Reality. A guide. Great. Okay. Thank you. Move on to the next one, which is really thinking about in what ways have the 10 essential public health services been useful, either to you and in your agency or to the field. What's your perspective? How have they been useful? Provided a guide and focus, a framework for the field, providing definitions, helping prioritize, guidance for PHAB, an ideal framework, new employee orientation, assessing effectiveness, credibility for elected officials, providing a perspective, informing governing entities. So a lot about using a communications vehicle, establishing a floor for services, a standard for the field. All right, we're starting to slow down. We'll give you another moment on this one. Highlighting gaps, practical planning. Tells what we should do. A yardstick for measurement, establishing credibility. More on communication and staff training, framework. All right, great. So if it were up to you to dictate the framework for the next 25 years, what would you do? Would you scrap it and create a new model from scratch? Scrap it but don't create anything new? Keep it as it is? Keep it but with minor tweaks? Or keep it but with major revisions? Select one. All right, it's fun to watch these lines move. So nobody's saying to scrap it and don't create anything new. A few saying it's fine as it is. A few saying toss it but create something new. And then a majority of folks looking to make some minor tweaks or keep it but with major revisions. And we'll come back to this and ask you for additional thoughts on this, both through the Slido poll and then during the discussion portion. So take another minute for those of you that haven't had a chance to weigh in yet. Still got a majority saying minor tweaks. All right. So let's get into the details. Which essential services would you recommend changing? And you can select all. So which of the 10? All right, 7 rising to the top. Quite a few for essential services, 8 and 9 as well. All right, we're going to scroll and see what some other responses are. There's still more than a quarter of you for the top few, 7, 8, 9, and 10. Similar for numbers 2, 3, 6. A little bit smaller for 4, 5, and 1. And still a few who say they're not interested in changing anything. We'll take just another moment on this one to make sure you have a chance to get through all 10. All right, looks like we've slowed down. So let's go ahead and we'll move on to the next question. This is also our final question before we move to the discussion portion, which is what concept or concepts would you change or add? So we started broad and here we're getting more specific. So health equity coming up a few different times and social determinants. Data capacity needing to be more clear. Health equity and health in all policies. Climate change, chief health strategist language. Some thoughts about research. Collaboration and cross-sector work. Data capacity, funding. I saw something on racism, changing social norms, built environment. So a few themes starting to emerge, data capacity specifically, more on research. mental health, business strategy, the voice of the public, move away from addressing individuals, surveillance versus research, data across sectors specifically, public and public health decisions, so that community engagement, plain language, interprofessional collaboration, risk communication, these are great, cultural intelligence, suggestion not to include topics that might change over time, cultural humility, cultural competence, or structural competence rather. All right, we'll give you just another moment on this one, and then we're going to turn it over to you. Please be sure to be typing questions into the chat box, and you can also, again, raise your virtual hand, and we'll call on you and unmute you one at a time if you want to participate verbally. All right, we'll leave this poll open while we're talking. We'll first go to the phone lines, and I'm scrolling here to see if anyone has raised their hand. All right, it looks like we have a question from Francis. We're going to go ahead and unmute you, Francis, and then you can ask your question. All right. Francis, are you on the line? If you are, you might be on mute. All right, we may need to come back to you. It looks like Adrienne Griffin has her hand raised. So Adrienne, we've just unmuted you. Would you like to go ahead?
Great, thank you. So this is Adrienne Griffin. I'm from the Association of University Centers on Disabilities, and I represent our National Center on Disability and Public Health. And my comment/question is around where are there opportunities to integrate a disability awareness perspective? And I say this because it is possible to hit the workforce and not be totally prepared to serve the whole community. With our changing demographics, there are now 1 in 4 Americans living with a disability. So I would like to just have a little bit of discussion around that if we could. Thanks.
Great. So you were cutting in and out a little bit, but I think I heard the question. It was just about accessibility and the changing demographic of individuals in the country. I think you noted 1 in 4 individuals living with a disability, and so having a conversation about that. I can start, and then I'll turn it over to Katie or Rena, but what I would say is I hesitate right now to talk about what changes we will make because we haven't looked at the data yet. So I think what you've raised is a suggestion that will go certainly into the data collection and as something that's missing for us to consider, but I hesitate to make any statements now about, you know, we will do this or we will do that, because it wouldn't be fair to the rest of the data. But I don't know, Katie or Rena, if you have anything you want to add to that.
This is Katie. I mean, I guess I would just agree with you that that's a very important issue, and would be happy to hear more about ways in which that can be worked into the framework.
Yeah, so thanks, Katie. So Adrienne, I think if you have specific comments, if you haven't already put them either into the Slido or feel free to just, you know, send us an email. That would be great and good fodder for discussion for later.
Yeah, this is Adrienne again. I think the major opportunity is around integrating a disability awareness component, especially around the assuring a competent workforce. What I'm finding in my work is that many in the field are just not aware of how to make their health promotion and general public health programs accessible because they're not trained. They just don't have that awareness. So to me, that's the major gap and the major opportunity.
Thank you. Let's scroll through and see if there are any other hands. Otherwise, we do have a few questions that have come in the chat box. All right, well, feel free to raise those hands throughout. Rena, I'll turn it over to you to share any questions that have come in through the chat box.
Great. So the first question we have here is, could you talk a little bit more about how we're defining health here and who's entitled to health for the purposes of the framework?
I think that's a great question. We haven't convened the task force yet, but if I had to guess, I would say that they would probably adopt the World Health Organization definition or something similar rather than trying to create something different. I think from our perspective, we're certainly defining health very broadly. And what you've seen today is very similar to data that we've been receiving throughout the data collection phase with regard to equity being something that's missing from the framework. So when we talk about who the framework is for and what a healthy community means, and it's health for everyone. And I think equity is certainly going to be a big topic of conversation. It's come up quite a bit.
Yeah, this is Katie. I would just add that I thought that was a really important question to raise, and I think that a big part of the work of this task force will be around definitions, because I think that it's important to be explicit about what we mean with terms that we use that may mean different things to different people. I would also just say that, you know, we were well aware that equity was missing from the framework before we even thought about who might be on the task force, and we very consciously invited folks who have been outspoken and really thought leaders on the topic of equity to the task force, and of course are very interested in what everyone in the field who wants to speak up about this project has to say on that topic. So thank you for raising it.
Great. So the next question we have here is a two-parter. One, will there be a report of the data collected from the polls and other data collection events like the town halls, et cetera, available to those who are participating? And two, where can we get a recorded version of the town hall afterwards?
So to the second question, the recorded version will be available in the next day or so, certainly on the PHNCI website. So that'll be very easy for you to access. And with regard to a report, we'll have a very detailed report that will go to the task force. We're working with a communications firm to figure out how to best communicate with the field in general. I think, you know, we certainly aren't trying to keep anything a secret. So I think we're happy to share what we're hearing, and then that would come out along with a draft of a theoretically revised framework for vetting. The framework will be available for vetting in late winter, early spring, with some explanation of where that came from. So the short answer is yes.
Great. And I do want to acknowledge, I know several folks are submitting comments for us, so we are seeing those and we'll reflect on those. I'm focusing right now on some of the questions we're receiving. So your comments are in there. Don't feel like we're not receiving them. The next question we have is, I know PHAB is working on the Accreditation Standards and Measures 2.0. How will this effort around refreshing the 10 essential public health services align with the updates that PHAB is doing and other efforts in the field?
It's a great question, and the timing is perfect for what PHAB is doing with regard to version 2.0. Of course, we mentioned at the beginning that PHNCI is a division of PHAB, so there's a nice connection there that's pretty intentional. PHAB is currently working on version 2.0 of the standards and measures. Our board here at PHAB is engaged in this body of work, as well as the body of work related to version 2.0 of the PHAB standards and measures. And so they'll be having conversations as a revised framework comes out, both for vetting and then a final framework later next spring on what that means for PHAB and what PHAB might do with regard to version 2.0, given that the current standards and measures are based on the current essential services framework. So that is a conversation that we continue to have, and we'll be sure to keep the field informed on that. I'll also say that part of what we'll be doing when we share the revised essential services framework is creating a number of alignment documents to articulate to the public health community how a revised framework aligns with other existing frameworks, so that it's very clear to see any differences between the revised framework and the original framework, between the revised framework and the foundational public health services, between a revised framework and the PHAB standards and measures, et cetera, so that it's very clear and that there's clear communication about how and why a variety of frameworks exist for different purposes. So we are paying very careful attention to that.
Great. Another question we have is, this is an opportunity for public health to really enhance our relevance to the public. How is this effort planning to get community input?
So we do have a public vetting period that will be, again, available once a draft framework comes out late winter, early spring. To date, we've focused on collecting input from the public health community and anyone that they would like to share it with, and starting in kind of an iterative fashion, and then expanding and considering how we may or may not want to reach out to whether it's other sectors or the community. One of our goals is really, someone asked or commented about plain language. Again, that's why we're working with a communications firm to make sure that the language resonates. But we are here at the national level, and many of you are at the state and local level, and I would encourage you to please be getting feedback from your community, whether it's funneled through you into this process or whether you're inviting them on their own. You're our best conduits to reaching your constituents.
Great. The next question we have is related to a previous question. What are some opportunities to make our work and workforce inclusive to disabled people as well as marginalized communities? And I think that's related directly to ensuring the framework speaks to disabled people and marginalized communities as well.
I would kind of second what Katie said before. I mean, I think it's something that we've heard is missing, and that we need to have a discussion about how to make that inclusive. I'm not sure I have anything to add right now. Katie?
No, I think it's an important principle to keep in mind as we're working on this and figure out how to make this a framework that makes those opportunities possible.
Mm-hmm.
Great. I'm just scrolling through these questions here.
This is Katie. I see one clarifying question from, or clarifying statement really, from Adrienne Griffin, saying, questioning whether the definition of health equity would encompass disability, and stating that the area of health equity is another opportunity to include disability awareness in any updates we make. I think that's a great point, and definitely want to consider that as we define health equity.
Another question we have received is around the task force. Can you talk a little bit about how representatives from the task force represent various demographics, such as rural communities, as well as other aspects of professional and non-professional representation?
We did strive to ensure that there were practitioners from both large metropolitan areas. We have leadership from the Big Cities Health Coalition and a member of the Big Cities Health Coalition, balanced with leadership from NACCHO, of course, who represents all health departments, and at least one small, more rural health department represented there. We also do have a couple of state health departments who, of course, represent the entirety of their states, and so those states have both rural and larger areas. With regard to diversity in general, I think Katie mentioned this a little bit earlier. We tried to get a good mix of folks across the board. So there are people who are newer to the field or newer in their career who maybe weren't, at the table when the IOM report was written in 1998 and again in 1994, as well as some of those who were. We tried to get people who we knew would question things and say, both, why are we doing this? This should be left alone. And people who say, this should be changed and here's how. People who have different professional backgrounds and different areas of expertise, whether it's on a content matter area like health equity, or whether it's someone coming, for example, from the American Medical Association, and not only the usual suspects. We really tried to kind of broaden the pool, and as Katie said, be very deliberate about representation across the field. So the framework was created not just for governmental public health, but for public health in general. So we have public health in general, I feel, well represented. And again, it's not just the task force. The task force is guiding the work. And I don't have the number in front of me, but we have literally thousands of comments that have come in. We have hundreds, at least, of folks who've responded to the online survey, which is very similar to what you did today, just in a polling format. Have had, more than a handful of think tanks where we've asked these questions. So I think we're getting a really, really good and diverse cross-section of the field participating in this. And all of those people matter, and all of those kind of votes and survey responses are being considered equally.
Great. The next question we've received is the 10 essential services were meant to operationalize the 3 core functions. Has there been any discussion for this effort in discussing or adding any of the core functions as well?
Katie, do you want to start, or do you want me to?
I guess what I would say to that is that we started this whole process with the question of kind of what should we do? Should we completely start over, or should we make smaller tweaks or larger changes or whatever? And so all of the options are on the table. And I think that goes to, if you were to change the entire framework, which to me includes the core functions as well as the 10 essential services. So I think, yes, we are open to that. I have not heard a lot of discussion on that topic, but happy to hear thoughts about that and get that information as part of this information gathering process. And I see a follow-up question. These are all good ideas, but is the essential services the right place to redefine public health practice? Is there another vehicle? I think we saw an opportunity with the 25th anniversary of the essential services, and then we saw this opportunity to work with PHNCI and with PHAB as a way of being able to really socialize what we come up with the field. But if there are other ways to have this conversation that maybe, I don't know, if they're more radical or more conducive to major transformation, we're certainly open to that too. But I think I hear the question, and I guess I'm interested in the opinions of those on the phone about this. I don't know that it's a question for us to answer.
I also think, Katie, it goes back to the questions that were on the slide at the beginning of the call about, you know, for whom is the framework intended and kind of what is it intended to be. And if, for those of you who remember, or if you read the environmental scan, you know, this framework was born in 1994 as part of the Clinton administration's health reform work. And it was really to define public health and help communicate it to the public and to policymakers. And so that's one of the things we want to consider is that still the right thing for the framework to be for? There are other frameworks. They do different things. There are the foundational public health services. Those don't define everything that public health does. Those were developed for a specific reason with a specific person and focus, or with a specific purpose rather, and focus on, you know, particular things. This framework was developed for something different. So I think those are conversations to continue to have. But from my perspective, as a framework, it's the most comprehensive definition of public health practice, not limited to governmental public health practice, but to all of public health practice. So it seems like a natural place to start and to focus our energy.
Great, we have another question that's just come in, which we've addressed a little bit earlier, but I'll go ahead and ask it. Have there been conversations around disparities surrounding, oh, I misread this actually, I don't think we've addressed this, border health and how the functions can address that?
So the answer is no, because we haven't had discussions about what we've seen in the data yet, because we're still in the midst of data collection. So we haven't had discussions about any changes that should be made. We've simply been collecting the data. I can't speak to all of the data because analysis is still going on, so I don't know whether it's come up in the survey or in a Slido that I didn't participate in. I haven't heard it come up, so nothing that I've been part of. We haven't had a verbal discussion about it in a setting like this. That doesn't mean that it's not a suggestion that's in the data for consideration when we get to that point.
I see a question that I would love to answer, which is why not put this back through the IOM? And I appreciate that question. A couple of things I would say. First, the IOM came up with the core functions, but it was actually the Essential Services Steering Committee that came up with the essential services. But we did consider a number of different ways to go about this process, and I think one of the driving principles for us was that we wanted as much field input as possible. We wanted as much input from people who are actually working in public health across the country, whether they're on the front lines or leaders in management positions. And the way the IOM does its processes, it's fairly exclusive. They tend not to have a lot of data gathering from hundreds and hundreds of people as part of the process. And that was something we really wanted to do. So we wanted to work with a partner who had more reach into health departments and the public health system more generally, which is why we thought of PHAB and PHNCI.
Great. Another question we've received is, how will the task force address the issue of implementation of the 10 essential public health services and its comprehensiveness, completeness?
So I can take a quick stab at that to say, I think that's beyond the scope of this project. This project was really about revisiting the framework and making sure we have the right framework for the next 25 years. I I don't know if another project will come out of this that will be looking at implementation. I could see accreditation being part of the answer, but certainly wouldn't want to speak to that, and I don't know if any of my colleagues feel comfortable speaking to that sort of long-term implementation question.
I would just reiterate what I said before about, our board being a part of this by virtue of being our governing board and considering how this will impact PHAB moving forward. So it's certainly on the forefront of everybody's mind. I'll also say some of the conversations we're hearing, and it's interesting, we'll have people who work at different schools or programs of public health that say, all of our students have to learn this, and others say, wow, we don't teach this at all. And so I think when we think about implementation, and that's just one example in a university setting, we want to make the best framework we can so that the field finds it useful, so that the field can use it in a manner that it will be intended for, which is within the scope of the project, to make it as good as we can. But like Katie said, beyond that is not on the table at this point. These are really great questions, a few that haven't come up before.
Great. Another, I think, related question to next steps after creation of the framework is, how will we inform the general public about what their local and state health departments are and should be doing in terms of essential services? And how do we include that within the framing for the services?
So I would offer that doesn't start and stop with the development of a new framework. That's something that health departments are doing, presumably on a daily basis, and working, with their communities, and hopefully helping their communities to understand the value and relevance that a governmental public health department brings and the services that it can offer to the community. So I wouldn't wait until this framework exists. I think that's something we should be working on now. I think, again, we'll have, communications tools to help describe the framework, to help explain it. And I would leave it to the individual health departments to determine how to best work with their community based on what their community needs and needs to know. I don't think what we're doing here is redefining public health practice in a way that's going to say health departments should change everything they do. I think we're putting a framework to what health departments are doing now and can be, looking to do in the future. But that's a little bit different than suggesting that we're going to put out a framework that says, stop what you're doing and now do this, which is a little bit of how I interpreted that question. So perhaps I'm misinterpreting it, but that's my read on it.
Great. Another question we have is, do we know why some schools use the framework and some do not? And is there something that can encourage increased use? Helps to make sure we're all on the same page.
It's a great question. I can't speak to the why. It's just a little bit about what we've heard. What we're doing to try to ensure that schools do we do have a number of schools represented on the task force, and those people hold positions within, ASPPH to be able to feed back in. We also did have a meeting with the ASPPH Undergraduate Council and are working with them to ensure that we get feedback from their members, and I think the extent to which their members participate in this process and feel that their voices are heard and are represented. If we can make a framework that's useful, we certainly hope they'll use it. Obviously, in the CEF requirements, it speaks to the 10 essential services. So there is that. We also know that a lot of our workforce in public health doesn't necessarily come from a school or program of public health, but we have heard that a lot of health departments do use this, and you saw it represented here to train or orient new staff. So certainly we won't limit ourselves to thinking about the schools when we think about how to use this for the workforce.
Great, and that's all the questions we're seeing for now. We have a few more minutes, so feel free to chat those in if you have any additional questions at this point, or raise your hand.
Great, and while we're waiting for that, I'll just make this statement. I think all these questions are great, and thank you for asking them. We've done our best to answer them. It's not your only opportunity. You can feel free to reach out to us if there are other questions that occur to you later, if you'd like a little bit more information. But I do want to say, we understand, and part of the environmental scan, I think, helps to show the importance of this framework to the field. And so we don't take lightly making any revisions to it. And I hope you feel confident that we're going about it in a very deliberate and very thoughtful manner, and not relying just on, the wisdom of partners at the national level or the federal level, but looking at practitioners and looking at public health practice in general to try to really get as much feedback as we can. And it's not perfunctory. We're really doing this without thought of what the data is going to look like. We want to see what the data looks like before making any kinds of conclusions or any kinds of suggestions. So we do take that very seriously, and I hope you feel great about your participation today and into the process. And then as a reminder, when a revised framework does come out, you'll have another opportunity to weigh in. So if you don't think we get it quite right, you'll have the opportunity to share that with us and to suggest improvements. Katie, is there anything you want to say? We do have about 2 minutes left.
No, I would really just say I am looking at all of these questions and feeling like a lot of them are really thought-provoking, and I really appreciate your joining us today and asking them. And I feel like most of them aren't things we can answer today. They're really more things that become part of the data collection. And I just want to express a really sincere thank you. I hope you can tell from the hesitation in my voice. I just have so much thought going on because of these great questions that you've asked today. So I'm sorry if we didn't answer them in a way that was satisfying, but I hope you all know how seriously we take them and how much we will work to make sure that they are definitely taken into consideration as this new framework emerges. So thank you for that.
Great. Thank you, Katie. And I think that's a perfect way to end, as thanks to everybody on the line. And we look forward to being in touch as this unfolds. Again, if you have additional thoughts you want to share that you weren't able to share today, feel free to send us an email with those thoughts. And thank you all so very much for your participation. Our websites will also be kept up to date as the project unfolds, and so that will be one way to stay up to date. With that, we'll let you go back to your days, and you can now disconnect. Thank you so much, and goodbye.